Hello, lovely friend. I am Dr. Mary Barson.
And I'm Dr. Lucy Burns.
We are doctors
and weight management and metabolic health experts.
And this is the Real Health and Weight Loss Podcast.
Hello, lovelies. We are super excited to be bringing you this series in menopause where we're interviewing guests on their expert subject regarding perimenopause, menopause and beyond. As always, any information in this podcast is just considered general advice, and we would urge you to seek medical attention if you have any concerns about your health. If you're interested in exploring the symptoms of menopause or perimenopause, we have a checklist which you can download at our website, rlmedicine.com/checklist, or as always, you can click the link in the show notes. Thanks, lovelies. Enjoy this series. Good morning, gorgeous ones. How are you this morning on this beautiful Tuesday morning? This is the start of our menopause series. I'm super excited to be bringing you really expert guests who are going to be delving into all the different aspects of menopause. And I thought we'd start the series off with one of the best experts I know. Her name is Dr. Ceri Cashell. She's a GP with a significant interest in menopause and runs a fabulous menopause clinic. Ceri, welcome to the podcast.
Hi, Lucy. Thank you very much for having me.
Oh, you are welcome. So what I want to know, and I've spoken about this a little bit, is that, I feel like I'm a bit late to the menopause party. I haven't, and then I go in and find out, actually, I'm not that late. But you're like a forerunner. And I'm really interested to hear how you found yourself into this space and how you help women navigate this period.
Yeah, so I actually feel a wee bit of a cheat because most experts in this space have got this quite tragic personal journey, whereas I feel I kind of sneaked in before anything too awful happened. And for me, it started with a patient back in 2021 who came to speak to me about her menopausal symptoms, and she had already started estrogen and progesterone, and it wasn't really cutting the mustard for her. So she'd gone off to see somebody else and got started on testosterone. So she came back to me and said, I want you to take it on. It's changed my life. And I was like, I have no idea about testosterone. And she said, well, you need to do this course. You need to look at this doctor in the UK. And it took me a couple of months, but I did. And I did this course, which is the Dr. Louise Newson's Confidence in the Menopause course. And then I started to listen to her podcasts, and I was running up and down our local beach, which is Palm Beach. My head would explode every day that I listened to each of those stories or each of the interviews with other experts. And I realized that really I had essentially sleptwalked through the past 20 years of women's health medicine. And I could see a patient that matched those stories pretty much in every single case. And from that point on, I started to look at women with an entirely different lens, and women of all ages. So it was really like without sounding too evangelical, it was like an awakening, really, in medicine for me. And I have never enjoyed my job so much as I do now, since I've changed our practice.
I love that. And I think it's amazing when you do find something that makes such a big difference to what you were doing. And, when I first found sort of low carb as one of our pillars, I had a business which I called Epiphany Medical Weight Loss, because a bit like you, I thought, I've had this epiphany, this awakening. But then I changed the name because two things happened. One, some people didn't know what an epiphany was. And so then I had to kind of explain it, which sort of lost its impact. Some people thought there was some religious connotations to my practicing. And then the third lot of people were calling it epiphany. And so I thought, actually, I'm not going to call it that. So
I like that. I like epiphany medicine.
I know. Well, actually, in the menopause space, it really is a bit about the epi and the fanny. But
yes,
let's move on. So I think a couple of things that I've noticed is that the symptoms that people have. I mean, if you ask about menopause symptoms, they'll talk about hot flushes and maybe night sweats. But there's a whole lot more going on. And I thought that you would be the perfect person to explain what are the symptoms that people may be having as part of their menopause transition.
Yeah, so that's such a good question. And that, I think, really underpins the whole of women's health. And that's what I've loved most about my learning about menopause, is I understand everything a little bit better. So I always go back to estrogen, or really the important estrogen in menopause is estradiol. And I do think it's important to understand those subtle differences. So every single cell in our body has got estrogen receptors on it, and estradiol, when it clicks with those receptors, controls those cells and keeps them organized, keeps their energy up. So once you understand that principle, you can see that any single symptom that a woman experiences could be down to changing hormones. And that applies in our menstrual cycle, that applies after we give birth or when we're breastfeeding, that applies when we're on certain forms of hormonal contraception, and then it really applies in perimenopause and menopause. So I would say almost any symptom a woman experiences could be down to perimenopause and menopause, but the absolute importance is that it isn't always the case. And that's very much what we as doctors are always trying to navigate is this a perimenopause or menopausal symptom, or is it something else? Because women in their standard age range for perimenopause and menopause are getting a bit older and do have an increased risk of other diseases. So I break down the symptoms into 3 groups. I think you probably can split them in different ways, but I like to think of them as symptoms that happen in the brain because they're often the earliest symptoms. And I think they precede a lot of the classical changes that most doctors and most women have heard of, which would be your periods changing or the hot sweats or the hot flushes and the night sweats. So the brain symptoms, I think, are the ones that really cripple women and make them reduce their hours and make it harder to manage life. And that would be things like anxiety, insomnia, change in brain function, difficulty with verbal fluency, finding words, and also even the temperature regulation thing does come from your brain. So those hot flushes and night sweats do have an origin in the brain. So I like to think of the brain symptoms because most of us really value our brains and they tend to allow us to live our day to day. And then I sort of go neck down, and then it's really anything. So common symptoms that women get in earlier stages of perimenopause would be palpitations. So you've had all these women that I've referred for multiple investigations, ECGs and heart monitors, and off to cardiologists and off for echocardiograms and such like. And then it was probably just perimenopause. And then gut symptoms, really, I look back at all the women who've been back and forward to gastroenterologists and had endoscopies for changes like reflux or constipation or diarrhea. Our bones really start to, be affected well before our last period, which I didn't appreciate at all. And we think that's even more to do with progesterone dropping before estrogen. And so really looking at bone density as soon as a woman is in menopause. But women often get joint pain. I have a good friend who's a physiotherapist, and she was seeing me with her really sore feet, and we both run Palm Beach, and she was sort of hobbling along trying to manage about 20 meters. I met her there the other day, and we ran the beach up and down twice together, both of us feeling delighted with our physical fitness. And I think the joint pain is a big thing, and and women know that they need to exercise at this point in their life, to stay fit and healthy. But if you're so sore that you can barely get out of bed in the morning, then it's a wee bit rich for me to say, take yourself off to the gym, just work a bit harder. And I think that's certainly a symptom that people find really difficult. And the other thing that people get is the sort of the effect of the nerves, in the rest of your body. So that tingling feet or that creepy, crawly feeling on your skin, and just feeling like there's ants crawling. My only symptom, as I say, I was a complete cheat, was a itchy back, and the occasional itchy ears, which I think are hilarious symptoms, but equally quite annoying. I could probably scratch my back raw, and I do quite a lot of because I still do a lot of general practice as well as menopause. And my older ladies who have these raw backs, they've got a thing called nodular prurigo, which is just basically intractable itching and scratching, and they scratch themselves raw, and that continues, and that's loss of estrogen in your skin, and probably also testosterone and progesterone as well, keeping that lovely moisture in our skin, keeping the collagen and the elasticity there. So so that's the thing, it really can be any symptom. So it's always trying to juggle, not assuming it's menopause, but equally not over investigating somebody when it probably is, because as we know, common things are common, and all women, if they live long enough, will go through menopause. So, and most of them won't have brain tumours, so it's a juggling game of general practice.
Yeah, I love that. So the idea being then that any symptom, and I do, recognize that, as you're saying, the estrogen receptors are in all of our cells. So any symptom could be menopause. Obviously, we need to exclude serious conditions because we don't want to write everything off as being menopause. But if we've done that, and I think this is where women in the past have had difficulty, where somebody has perhaps investigated them and then said, oh, no, there's nothing wrong.
Yeah, I think that's huge because what's happening is really at a cellular level. So it's not necessarily translating into a full disease process. So, you've gone off and you say, like, my memory's not as good as it was, or my joints are really sore and I'm in a lot of pain. And you go and see whatever specialist or just your GP, and they run your bloods and they go, your bloods are normal, so you're fine. And I suppose that's one of the things that gets called medical gaslighting, and I think not having your symptoms validated or even just having a reason does compound that feeling that you might be just going a little bit mad. And just to understand, whatever path you choose to take, just to understand the why. I think for women or for all humans, why do I feel like this is so empowering to go, that's why. Oh, well, that's okay then. I don't need to worry that I'm going to, have rheumatoid arthritis like my mum, or I'm going to have dementia like my mum, or, whatever it is, just to know and understand. Like, knowledge is so empowering.
Yeah. Absolutely. And I think the thing that a lot of people will say, I went to the doctor and they told me it's just my hormones, and feel like they weren't heard. And whilst the premise may be correct that it is hormonal fluctuation, it's really explaining to people what that actually means and then what their options are, rather than them leaving going, I feel like I've got no solution because it's just my hormones.
Yeah. And I think that goes back, I often start off when I'm doing talks saying, well, what is a hormone? So because it's really, they've been kind of demonized. We've got lots of hormones, and hormones are how our bodies work. If we had no hormones, we'd just be like, I don't know, I'd be just a blubbering pile of jelly on the floor, so nobody disses serotonin and dopamine and melatonin and thyroxine and insulin and leptin and ghrelin, so why do we demonize our sex hormones? I reckon they're the boss babe hormones. They're up there going, like they're the chief executive suite, So the sex hormones, and we're designed to reproduce, so it makes sense that the hormones that are involved in reproduction do have a very strong role to play in human physiology. And you can see that in men. Men are able to reproduce usually until they die, and they have that lovely testosterone that, although it declines decade on decade, it's hanging about really pretty much till the end. And it was really noticeable. I used to do the park run before my hamstring got a wee bit fragile, and I was the oldest woman doing the park run. I think there might have been one other woman a bit older than me, and that was at 47. But there was men in their 60s firing past. I was like, where are all the older women? We're not lazy, so why are we not here and present? And you just, without the hormones, you just can't maintain that physical fitness. It's just nature, So I'm not up for that. I want to be doing my park run at 65 or 70.
Yeah, 85. Why not? Why
85,
not?
Bring it on.
Bring it on. Absolutely. One of the other things that I think comes up a lot is when people have blood tests, and they will have the blood test and then they'll come away with the impression that, oh, well, my hormones are all fine, so it's not my hormones. Or, oh, yeah, I've had my hormones done and I'm through it, so, I'm finished, so it's not my hormones. So what are your thoughts on blood tests, and when do you order them, and what do you reckon is the process that women should be looking for with this?
So one, again, it's like a hormone's just a messenger. And my second key point is blood tests don't diagnose perimenopause. So in perimenopause, as you obviously know, our hormones are up and down and all over the place, spiking. Estrogen will spike high and trough really low. Progesterone probably is running generally a bit lower than it was. But because they're different day to day and hour to hour, snapshot blood tests don't tell us a huge amount. And, there are some testing protocols there that are quite expensive and complicated, and there's not a huge amount of evidence that they make a huge difference to what we do. Hopefully in the future we will have ways of, maybe diagnosing perimenopause, but we don't have it at the minute. So blood tests do not diagnose perimenopause when the ovaries are producing eggs, occasionally on eggs of less, maybe of poorer quality, but occasionally the eggs will be great quality and your estrogen will be super great again. So the blood tests that we do, as I said earlier, are to just make sure those symptoms of perimenopause or menopause are not down to something else. So we're checking, that your iron isn't low because of heavy periods, or that you're not hiding something sneaky in your gut. We're checking your thyroid. We're checking, I would tend to do a metabolic screen at this stage to see where your sugar control is and your cholesterol and your liver function. And, maybe I'm checking that you're not anemic. And I do often check testosterone because I'm a big advocate for test checking and seeing if testosterone has a role to play. So I will tend to check a testosterone level, but estrogen levels and progesterone levels, in my experience, don't have a huge role, except when you're trying to see if if drugs are being absorbed. So we're really using blood tests and other investigations to rule out the not perimenopause. And then in postmenopausal women, you will see a change in blood tests. So when there's been consistent failure of ovulation, so the periods have stopped for a while and the ovaries really have become senescent, which is not a word I like, but kind of
no, it's fancy.
Retired.
Yes.
So
yeah, they're finished.
Well, the healthy postmenopausal ovary, I think, should still trickle out some testosterone, but it can't make it into estrogen anymore. So they're still doing a wee job, because we know women who have their ovaries removed do tend to suffer worse health consequences, even if it's done at a normal age of menopause. So bloods after menopause, again, are to check for the other, and certainly to keep an eye on things like cardiovascular risk factors, but also we can see they do confirm that you're menopausal, but it's not usually recommended, because if a woman is over the age of 45 and her periods have stopped, then she's in very much in the normal age range of menopause. But the problem is our guidelines confuse doctors. So they say that women under the age of 45 should have blood tests to confirm menopause. And we've missed, therefore, the nuance that women under 45 or under 40 or under 35 and so on, if they're in perimenopause, it doesn't matter what age they are, their bloods will still be normal. So that guideline, I think, has misled doctors a bit. So it's really important that we diagnose early menopause or primary ovarian insufficiency, which is women who go into menopause under the age of 45 or under the age of 40. But if they're in perimenopause, the blood test will still be normal.
So for our listeners, to make it really clear, how do you diagnose perimenopause?
Yeah, so it goes back to one of the best investigative tools that we have, which are the two big floppy things that sit on either side of our head. So just listening, that's the way I had brilliant GP training, and I really taught that, 90% of your diagnosis is just in the history taking. And history taking, can be a bit of a challenge for me because I do like to talk. So really, just sitting there, keeping your mouth shut and just let the person talk, and so many women will say, I think it might be my hormones, but if you just let them talk, you'll often see all these different symptoms. And yes, there's usually a lot of social factors in a woman's life when she's going into perimenopause that you could think, well, maybe you're just doing too much. But I think if you listen, you can hear the story, and I think that's something we need to go back to the basics and just sit there, shut up, and let the patient sort of lead, the consultation.
Yeah, absolutely. And I know there's lots of checklists out there, and we've created one for our website too, again, that people can download and fill in and go, yep, I'd have this, I have this, I have this, oh, I don't have that, oh, I haven't got that, but I've got this, and this is a little bit, not much. And so I think if women can take this checklist to their doctors, and then they've got sort of a framework to work with and go, well, these are all the symptoms I'm experiencing. And I know that, each one individually, again, isn't necessarily diagnostic, but when you look at it as a whole, it becomes pretty clear what's going on.
Absolutely. And I think it's very persuasive. I obviously, because I am so hormone focused, I give those I sit and do those checkers with women, because still a lot of women haven't considered their hormones. They think it is stress. But for the women who have thought maybe it is my hormones, coming in with one of those symptom checkers with the word menopause branded across the top, it's a nice gentle nudge to the doctor to think, well, somebody else has made one of these checklists. Maybe there's something in it. This woman clearly isn't making it up. So I think it can really help nudge a doctor that maybe isn't so perimenopause trained, of which most of us aren't, because all of us had zero training in perimenopause and just, lip service training in menopause. And it was really just that your period stopped and you got some sweats and flushes. And none of us were taught anything really about the cycle. Well, I certainly wasn't taught about psychological symptoms of perimenopause or neurological symptoms, or indeed that every single cell in the body had estrogen receptors. And I think that was already well established knowledge back in the 90s, but it just seemed to exist in the shadows.
Yeah, I had no idea either. And it only came to me, I did a talk quite a few years ago now for Low Carb Down Under on menopause. And so I was doing my research and I go, oh my God, there's estrogen receptors everywhere. And, you go through every system, brain, musculoskeletal, cardiovascular, as you've said, gut. And estrogen in particular is so protective. It's such a great hormone. Like I tell people, you're going to love estrogen by the end of this. Like who wouldn't want to have estrogen as their best friend? And then it just runs off, disappears. It's like, oh.
Yeah.
It's like,
so, I mean, so all, and I'm a huge advocate of lifestyle as well. I'm certainly, I think, throw everything at it. And I do worry for people who really focus on the lifestyle only, because we know there's better return, with weightlifting. If you've got a little bit of estrogen running in there, you'll get more muscle, return and, all the nutrition in the world. I'm not sure you can eat your way back to estrogen, because if you could, we wouldn't need ovaries in the first place, so we do need a wee bit of everything there. And I've gone on a wee bit of a deep dive into, the whole why have we demonized estrogen so much? And I do think that women were getting a wee bit out of control back in the 90s, and somebody decided that we needed to be put back in our box. And suddenly we had a big trial that came out and said estrogen was the devil's work, and women were scared off for the next 22 years. So it's been hard to work to run that back.
Yeah, absolutely. Women and doctors, obviously. So doctors are the gatekeepers of HRT, and yeah, we were all told that we've done a huge disservice to women by giving them HRT, and that, we're responsible for killing them with cardiovascular complications. And so everyone went, oh, well, that's not what I signed up for. So stopped.
Yeah, no, my mum was a GP, so she's 25 years older than me, so she remembers that coming out, when she was, and she would have been a menopausal woman herself at that point, and saying how awful they felt that they'd been prescribing this awful drug. And doctors we're just humans as well, and we do tend to hold on to bad news like anybody else, and it's very hard to undo those negative sort of stories where, like, our brain, we're scared of hurting people.
Oh, of course. But I think also that, there's been some evolution in the way we can prescribe estrogen in particular, and progesterone actually, which have made it, therefore, the people that were affected by oral estrogens and synthetic estrogens can now take it in a different format. So that's super helpful.
Yeah, so I think, so our new type of hormone therapy, whether you call it menopause hormone therapy or hormone replacement therapy or just hormone therapy or just sweet potato juice, I call it, because it's made from yams, and it's the closest thing to plant-based medicine that we have. So I tend to prescribe, I keep my toolbox really simple because it works for the majority of women, and that would be estradiol, which is the good estrogen, the anti-inflammatory, battery-sparing estrogen, as a patch or a gel, mostly a gel because you can't get patches for love or money. So that goes in through the skin. And when something goes through the skin, it bypasses the liver. And without going over technical, it means that women who might have an increased risk of blood clot, whether they've had a history of one or a family history or a clotting tendency, they can still have estrogen. And, it is really safe, and it is safe in women with a history of heart disease. That really makes the estrogen as safe as it can be by going through the skin. Although some women do have a real shocker, they don't absorb it, and that they can be difficult. So there is, because it's quite complicated how drugs get in through the skin. So we need a wee bit more work in that area. But the majority of women tolerate the gel or the patch pretty well. And yes, you're right. The big change was the change of the progestogen, and the progestogen has largely been there really playing second fiddle to estrogen and considered to only protect the lining of the womb for people who still have a womb at the time of menopause or perimenopause, because some people have had hysterectomies. But it actually does a lot more than just protect the womb. So natural progesterone is like nature's anti-anxiety and sedative drug. It works on the same receptors that Valium does, and it gives women beautiful normal sleep. Not all women, but, a good number of women. And they've done studies and they've shown that unlike Valium, you actually maintain your normal cycling of sleep. You get your dream stages and everything. And it's certainly, part of why women really love their hormones, because they sleep. And if you sleep, everything is better.
Indeed.
So progesterone, we have to give it orally, though. You can't give it through the skin because you just don't get enough to get into the womb. Some women, who've had a hysterectomy don't want to have progesterone or don't need to have it. The estrogen does enough. But some women, even who've had a hysterectomy, can have progesterone to help their sleep. And you can have a Mirena, which also Mirena is a progestogen IUD, so it's a coil that sits inside the womb and has a very low dose of synthetic progestogen. So it's still very, very safe and doubles up by controlling the nightmare heavy periods that many women get in peri. Also works as a contraceptive if you're in a heterosexual relationship and your partner doesn't want to have a vasectomy, which is still my number one choice for contraception in perimenopause. It's got no risk to women. But you can have a Mirena and you can have oral progesterone on top, if you want for your mood and your anxiety. So those are the sort of things that are a wee bit out of guideline, but can make women feel quite nice.
It's interesting, just back to the progesterone, because I'm a little bit nervous of progesterone in some ways because of its effect on increasing insulin resistance. And we see this in just in your standard cycle, like when people are not taking hormones, just their normal natural menstrual cycle, they have a temporary increase in insulin resistance in that premenstrual phase. And so I've always been a little bit wary of prescribing progesterone if they don't need it, like if they don't need it for womb or uterus protection. But I guess it's then balanced, isn't it? Because if you're not sleeping, we know that poor sleep increases insulin resistance as well. So therefore, if we can improve sleep, then we will improve insulin resistance. And so like everything, I think there's always nuance, isn't there?
Yeah, I think I sort of feel, and I wasn't aware of the increasing insulin resistance thing, but I wonder if when you're giving it more in that sort of top up level, if it actually, I think there's so much in that premenstrual phase that's more about rapidly changing levels rather than the absolute levels. Like I wonder almost giving progesterone, if we actually steadied out that second half, would you see an improvement in insulin sensitivity? I think that's what's really interesting. So, women obviously have bad PMT, they tend to get, they get cravings and they overeat and, all sorts of weird things happen, which are clearly hormone mediated. But yeah, if you give them progesterone and estrogen, all of that goes away. And I think there's some wonderful research that could be done there that might be quite exciting.
Yeah, absolutely. And again, it's that the hallmark has always been for me noticing people with type 1 diabetes, their glucose control is often more brittle or up and down in that premenstrual phase. And I agree. There's definitely room for some research there by someone way cleverer than me.
Yeah, because that probably fits into all the women who get premenstrual epilepsy and all of those. Yeah, there's a lot of stuff and there's hardly any data. And I'm thinking, this is huge. Like these are women that live a quarter of their life at increased risk of, diabetes complications or serious epileptic fits. Come on.
Yeah, absolutely. And I know we're going to be talking further about this in the future on mood disorder, but also all the things that happen in that premenstrual period, migraines, everything. Like it's your hormones, baby. It's your hormones. And then you touched a little bit on testosterone, and I know that's controversial at the moment for many reasons, but I thought we would spend some time talking about it and how you use it and when it's appropriate and when it's maybe not appropriate. What are your thoughts?
Yeah, so testosterone was, as I say, that was the new one to me, although I was quite excited to find a letter that I'd sent back 11 years ago to the menopause clinic asking if they would consider it for somebody with low libido. So there's been a lot of research, really driven by people in Australia, and we are the only country in the world that has a licensed testosterone product for women. So that's pretty cool. But it's only licensed for a hypoactive sexual desire disorder, which is a long way of saying reduced libido for no other cause than just reduced libido, which can't be caused by illness or drugs. So after listening to Louise Newson and quite a few other thought leaders and who are doctors in the menopause space, started to think a little bit outside the box like they do. And I've started to prescribe it for reasons other than reduced libido. And I find it can be an absolute game changer for women who have persistent cognitive symptoms. So that reduced memory or brain fog or verbal fluency. Also, it does seem to help mood and can really stabilize mood, and also has an effect on pain and so certainly joint pain. There is some good data showing that it improves bone density. There's evidence that it stabilizes the lining of the womb. So I wonder how many of those women with heavy periods actually have low testosterone. There's evidence that it stabilizes breast tissue. There's evidence that it's anti-inflammatory liquid in our joints, in the joint matrix. So, and it does have good evidence for sexual desire and dysfunction. But I would say the effects on libido are probably the most underwhelming. And what's overwhelming is women just going, yes, I feel back to myself. Not necessarily libido. I think sex drive in relationships, that is so complicated, and that does require a lot of work. You need to, it's hard in midlife, certainly when most women are in perimenopause and menopause, to prioritize sex because you're doing 7,000 other things, and women need hours of foreplay, whereas we expect to get ready in 2 seconds, and if you think back to when you were a teenager or, in your early 20s, you shaved your legs at 4:00 and got your nails done, and how do we dance around your bedroom? There was hours of sort of psychological foreplay going on. Time for that. So it's not just that we're older, it's just that we're so much busier. But so testosterone, I really have seen it in some women, absolutely not all women. Some women do not notice any difference at all, and that is probably not hugely linked to their levels. So some women have undetectable testosterone, and that's partly because our assays are not good enough for women, so they're still very much based on testing for men. But where it works, it can be really great. It can be good for younger perimenopausal women, and I also use it in older postmenopausal women. So I do start HRT in women over the age of 60 and even older. And because when you start HRT a bit past menopause, it can trigger some vaginal bleeding, which might take a couple of months to settle. Those older women really don't like that. Some of them really don't like that. And testosterone can actually seem to work to do most of the symptoms, give them their sleep, give them a wee bit of extra energy. I've got women in their late 70s who are back at the gym lifting weights. That's what I want. I want these women to be able to move and, live their best lives. So yeah, testosterone has definitely got a much more effect than just reduce libido. And it definitely does not always work for libido. And it definitely does not work in everybody.
And then what are the concerns with it though? Because obviously there's, people worried about it. What are their worries?
So the worries would be that if you're replacing too much testosterone, you might cause, so if you're moving out of a woman's natural range, although we don't have a huge amount of data on what the natural range is, so I try and keep it reasonably close to the levels that I would see, which is a range of 2 to 3%. So the concern would be that your voice might change, and it will change. I think once you hit levels of about 6, and we see that in gender affirming care, your clitoris can become enlarged, and that is irreversible, and that will happen, I think, at levels of like between 6 and 10. You can start to get increased hair, but this is all in levels that are above a woman's normal range. So most of us who are giving testosterone to women, if we're doing it responsibly, we're watching the levels every 3 months and checking that it stays in the female range, and it shouldn't cause anything like that. The side effects can be you get a bit of oily skin, you can get some spots. Some women do see a little bit of hair loss, but it's usually temporary. And so in general, I would say it either works or it doesn't, and it rarely causes side effects. Actually, it has a lot less side effects than estrogen and progesterone, which tend to cause a lot of water retention. It works really slowly, so it tends to build up in the system over about 6 months, and you either notice something or you notice nothing at all. That would be my experience.
Absolutely. I love that. So honestly, yeah. So people making sure, and again, women, if you've been prescribed it, make sure you get your levels checked.
And don't overuse it.
Yeah. Like everything, more is not always better.
Correct. Definitely not.
So I love that. And I love the idea that, again, I know we had a chat about this. It's not lifestyle only and it's not hormones only. It's the combination for many women is where the synergy happens. So yes, you can do lifestyle and yes, you can have hormones, but when you add them together, they multiply the benefits. And, the tricky thing, I think, is for women who have had breast cancer, and I wonder what your thoughts are for them, because I feel like we're all now going on about, oh my God, hormones are going to fix you and make your life amazing. Oh, you can't have them. Sorry about that.
Yeah, no, I think that's so important. And I do think this is an area that we just really need a huge amount more research. And again, was another surprise to me or shock to me really is when you look at the data in hormones in women who have a history of breast cancer, the research is extremely mixed and overall actually favours it being safe. So there's 25 studies looking at hormone therapy in women with a history of breast cancer, and only one of the 25 studies showed an increase in recurrence. In that one study, when they recruited the women to come into the study, they didn't do a baseline mammogram, and the recurrences all appeared within 18 months. And breast cancer doesn't develop that quickly. So, I mean, breast cancer takes years to develop. So it's likely they had a little small recurrence sitting there and it grew. And even in that one study, when they followed them up for the next 10 years, there was no increased risk of dying from breast cancer. So I think this is an area that we really need to get our breast cancer doctors or oncology doctors to start looking a bit more holistically at women. And I think it's a very individualized discussion. You know, I see women who have had a history of breast cancer who really feel their life isn't worth living because of the level of joint pain or the anxiety or the insomnia. And they've already tried, 7 drugs to treat their, 40 symptoms. And they just say, well, I want to know if hormone therapy would make me feel better, and then I can decide if I want to go with it, knowing that we don't know everything that we need to know, but I want to make that decision based on how I feel. So, and I really very much believe that that's the woman's decision to make. If she wants to live the next 5 years as well as she can, but know there's a small increased risk of breast cancer, maybe, then that's her decision. But I don't think it's my job to say no. I think, women are most women are very able to make these decisions themselves. And I don't think it's my job to forbid them something that we know is going to reduce the risk of heart disease, dementia, osteoporosis, bowel cancer. But I know we don't know what it says about breast cancer, but we have a reasonable bit of data there that suggests that it's safe. And I think anybody that's listening to this that, has their interest piqued should read Avrum Bluming's book, Estrogen Matters, which is just phenomenal. He's a breast oncologist who has really done a complete about face about, how estrogen doesn't maybe cause breast cancer. So I think there's definitely, so much that we need. And it's to say in the male space, we thought testosterone caused prostate cancer. And they're currently doing a trial using testosterone to treat prostate cancer. So I'm hoping that, in 5 years, we'll have more trials using estrogen to treat breast cancer. We do have one running at the minute, but I would love to see more of that. Yeah.
Oh, absolutely. And in fact, there was that trial that just paper recently published that showed that women who are using just estrogen, so again, they've had a hysterectomy, so they don't need the progesterone protection, just estrogen have a reduced risk of breast cancer. And I love that. I'm thinking, right, so what that signals to me is that there's clearly more to this picture than we know.
Yeah, absolutely. I mean, I don't see how something can reduce the risk of breast cancer but simultaneously cause it. I think there is definitely nuance in there, and there's, we know there are things that do increase a woman's risk of breast cancer, and it's really important. And this often becomes a wee bit of a battle between hormone therapy and breast cancer, and it shouldn't be. It's about the health of all women and all of women's health. So breast cancer is really important, and it's really important that women do self-examine and do get screened, but it's equally important that those women get informed, consent about treatment and options for menopause. And I don't think that's happening at the minute.
No, absolutely. And I think that in the space that I work in, we know that metabolic syndrome, which is often, the symptoms that people present with metabolic syndrome are obesity, and we know that that increases breast cancer by miles more than estrogen replacement seems to. So it's like we're missing the big picture.
Yeah, I can't see, because a lot of women get terrible joint pain, especially on their treatment. I think, well, maybe if those women had a little bit less pain and a bit more energy and were at the gym and eating well and sleeping well, I kind of feel that even if there is an increased risk of breast cancer, it's still going to be negated by all of those other benefits, but I can't see how estradiol, I think estrone, which is a more inflammatory estrogen, I can't see how estradiol controls our little cells and, turns off, bad cells, how it can cause cancer. It just doesn't make sense. It might make things grow that are already there. And I think that's why cancers do appear on HRT maybe more quickly, but I don't think it starts the cancers off.
Yeah, so interesting. It's so interesting. Well, I'm just excited because I just think, watch this space, ladies, watch this space. There's more coming for us that, again, it gives us options. That's what we want, is choice options and, education so that people can make informed decisions.
Absolutely. I think, it's really, we've been too much sort of in this power dynamic that doesn't favor the individual. And I think, in medicine, it should be a partnership, a shared decision making, whereas, yes, I can go off and interpret information. But if you're going to bring me stuff and say, what about this, doctor? I should be listening to you because it's your body and, and you are the expert about your body. I might know a bit more medicine, but you definitely know more about you than I do.
Absolutely. I love that. So, Ceri, if people want to follow you, connect with you, where do they find you? What's the best place?
Yeah, so I currently live far too much of my life on social media these days. So I'm imaginatively named Dr. Ceri Cashell on Instagram, and I'm also Dr. Ceri Cashell on LinkedIn. But we are launching a menopause education platform for doctors and hope to make it patient facing in the next few months so that women can get that knowledge there too. And that's healthyhormones.au. So that's exciting.
It's very exciting. And listeners, Ceri is, as you can hear from her accent, Irish. So she has an Irish way of spelling Ceri, which is Ceri. And before I had spoken to Ceri, I'm looking there going, is it Cherry? Is it Ceri? Well, how do we pronounce this? But it's just Ceri. So yeah, Dr. Ceri Cashell, Ceri. Lovelies, we will have all of the links in the show notes, including our menopause checklist if you want to go and check it out, or you can just go to our website, rlmedicine.com/checklist, and that will give you all the things that you need to know, because we want you to feel empowered and be able to have open and frank conversations with your doctor about your symptoms, and then the two of you can decide the best treatment going forward. Ceri, this has been delightful. I've been so inspired by your knowledge, and hope that our listeners have found great value in what you've offered today. And I'm looking forward to our other talk coming up in the menopause series on PMDD, which is premenstrual dysphoria disorder, I think is the way we pronounce it. And we've got lots more goodness coming your way.
Thank you very much.
All right, lovelies, have a beautiful week, and I will talk to you all next week. Bye for now. The information shared on the Real Health and Weight Loss podcast, including show notes and links, provides general information only. It is not a substitute, nor is it intended to provide individualized medical advice, diagnosis, or treatment, nor can it be construed as such. Please consult your doctor for any medical concerns.